We're going to spend the next little bit talking about the national perspective and its impact here in the Commonwealth. And we have an outstanding panel. And I'm going to ask Mr. Quinones to help me with the panel and add to dialogue or conversation or questions as he sees fit. First, we have Dr. Omar Abubaker. He earned his DMD and PhD from the School of Dental Medicine at the University of Pittsburgh. He currently serves as the chairman of the Department of Oral and Maxillofacial Surgery at VCU School of Dentistry. He's the chief of the Division of Oral and Maxillofacial Surgery at the School of Medicine and also the chairman of the Department of Dentistry at the MCV Hospital. He's directly involved in teaching dental students and residents and is widely published in this arena. He recently earned a graduate certificate in international addiction studies from the International Program of Addiction Studies here at VCU, the University of Adelaide, and Australian King's College, London, England. We have Dr. Heidi Best. She's a board-certified emergency physician who served as the medical director of the emergency department of Sentara Princess Anne Hospital in Virginia Beach since 2011. She graduated from the University of South Carolina's medical school and completed her residency at Eastern Virginia Medical School, where she also served as chief resident of emergency medicine. She's also served on the statewide task force on prescription opioid abuse established by the VHHA Board of Directors in January of 2016, which ultimately developed a set of recommendations to guide opioid prescribing habits in hospital emergency departments. We have the Honorable Dr. William Hazel. And honorable he is, and something that Mr. Quinones may not recognize is that he owes a fair amount of royalties to Secretary Hazel, because many of us first heard of his book from Secretary Hazel and purchased it as a result of Secretary Hazel's recommendation. And I'd venture to say hundreds, if not thousands, of books have been sold in the Commonwealth.
That's delightful.
Yeah.
I love you.
Yeah,
I love you guys.
Yeah, he's definitely worth a holiday ham.
Okay. There you go.
So Secretary Hazel is serving his second term as the Secretary of Health and Human Resources in the Commonwealth, post he took first in 2010. He oversees 11 state agencies with a focus working across agency and secretariat lines. He's co-chaired the Governor's Task Force on improving mental health services and the crisis response and on the prescription drug and heroin abuse with the Secretary of Public Safety. He's a board-certified orthopedic surgeon and practiced in Herndon, Virginia for 22 years. As a urologist, I figured if an orthopedic surgeon could read and understand the book, I could.
Wow.
Then we have Dr. Lora Peppard. She's associate professor at George Mason University and project director of the Virginia SBIRT program, Screening, Brief Intervention, Referral to Treatment grant. She's practiced as a psychiatric nurse practitioner across the clinical continuum, including inpatient, emergency, and outpatient psychiatric settings. She's led innovative program development and implementation strategies for the underserved, the military, and serious mental health populations. She holds a DNP in psychiatric nursing from Columbia University, a master's in advanced practice psychiatric mental health nursing from Boston College. We have Senator Bryce Reeves, which is skipping one, so I'll go to Captain Timothy Ring next. Captain Ring is a 32-year veteran of the Department of Virginia State Police Department. He's previously worked as a patrol deputy for the Hanover Sheriff's Department, worked as a trooper in Virginia Beach and Hanover County before being promoted to Special Agent in Criminal Investigation Section in 1991. He transferred to the Drug Enforcement area in 1994, served in both Special Agent and supervisory positions until he was promoted to Lieutenant in 2004 and a Captain in 2010. Captain Ring is now the Division Commander of the Bureau of Criminal Investigation, Richmond Field Office. He's a graduate of Randolph-Macon College, the DEA Unit Commanders Academy, and the University of Virginia's National Criminal Justice Command College. And finally, Secretary Bryce Reeves. He represented the 17th District.
Governor.
Pardon?
He's made me a cabinet secretary. I appreciate that.
He's a senator.
I'm even with Brian now.
Secretary. Well, maybe
Let the record reflect I've been promoted.
My fortune. 17th District in the Virginia Senate since 2012. Served as a second lieutenant in the United States Army. Worked as a police officer and vice narcotics detectives for Prince William County. Currently serves as chairman of the Senate Standing Committee on Rehabilitation and Social Services, overseeing social service, corrections, alcohol, beverage distribution, and regulatory matters. Received his undergraduate degree from Texas A&M University and a master's in public administration at George Mason University.
No, other than
So I like to.
Senator, he reads pretty well for
Yeah.
urologist.
He probably reads film all day. They're pictures.
They had the orthopedic version with pictures, but so So I'd like to, again, thank the panel. It's going to start with Captain Ring. And one thing that we've learned in the Northern Shenandoah Valley over the past few years is that the law enforcement partners that we work with often know what's coming. And they see the trends as they're coming, and they can tell us, and they told us a year or two ago, you need to really watch fentanyl's coming. And fentanyl came, and our mortality skyrocketed. And so in your work with the Virginia State Police and seeing what you're seeing on a daily basis through you and your agents, what do you see coming down the road that we as a community need to be aware of and mindful of?
Wow, what a question.
So you're going to be here a while, right?
Yes, sir.
You guys do the Snickers bar?
I'll take all your time. Used to see heroin, and as our guest speaker mentioned, it used to be relatively low purity, and it was adulterated and cut by the dealers as it went through the supply chain down to the end user. And of course now what we're seeing with the Mexican heroin coming up across our border and into our country and being distributed by Mexican cartel networks is very high purity. You've heard the word fentanyl mentioned. This is a drug that you can actually go on the internet and order directly from China. I wouldn't recommend that you do that, but you can. And it's shipped in U.S. mail, U.S. UPS, FedEx, into this country directly from China. And those Chinese manufacturers are shipping large quantities of fentanyl to Mexico, and then now we have begun to see fentanyl introduced into the heroin with great effects on toxicity and causing overdose and overdose deaths. One of the things that we've also seen over the last couple of years is the analog drugs, the designer drugs. You've heard the term bath salts or spice, which is, it could be anything. Spice, we started seeing a couple of years back where they take a plant material and they spray a chemical on it, and then they put it in a brightly colored package and sell it as a convenience store, and people ingest this stuff not knowing what it is they're taking. And when we would take it, submit it to the lab for analysis, you could have submissions from the same store with a different chemical mixture, because the people that are producing this to sell, they don't care what's in it. They don't care what you're smoking. All they're caring about is the money they're making after selling these products. The same for bath salts. What is a bath salt? It's sold in little packets saying not for human consumption, and people are ingesting it. Several years ago, we worked two different shootings involving police agencies in Virginia. One of them involved bath salts, one of them involved spice. So you're seeing these very dangerous chemical concoctions. We're seeing chemists in labs changing molecules to create new drugs that aren't scheduled as being illegal under either state law or federal law. So it's difficult for law enforcement to keep up. It's difficult for our legislature to have to keep up with these new dangerous drugs that are coming out on the street.
We actually will have a bill this year to address the fentanyl analog, so that if it's just a molecular change on it, the Board of Pharmacy can do that automatically and declare it illegal so that you can go after it.
I was just reading another report in preparation for this evening's panel discussion from our Richmond laboratory for our Division of Forensic Science, listing some of the submissions that they're seeing. Used to be that a heroin user was taking heroin, and if we were doing an undercover operation, we either bought heroin or seized heroin, we sent it to the lab, we'll come back heroin. Well, now we're seeing cocktails of chemical drugs mixed in with that heroin and different analogs of fentanyl. And it's more dangerous for the end user, more toxic for them, and now it's becoming more dangerous for law enforcement to process handle those drugs, and more dangerous for our chemists at the lab, more dangerous for our first responders responding to overdoses.
Good. One of the things that Mr. Quinones has written about both and spoke about today is the supply component as relates to the current crisis that we have and the prescription drug issue that we have. And I got duped by the salespeople around OxyContin back in the mid-90s and kind of went down that road with multiple patients. And actually, interestingly, one of our members of our current drug treatment court clients is a person that I wrote her first prescription for narcotics. And so you've seen that continuum and the impact of that. So Dr. Abubaker spent a lot of time and effort and energy on helping educate students and future prescribers and residents and your medical community here in Richmond. How do you see we're doing in terms of getting the message out in terms of what is kind of responsible prescriptive?
Well, thank you for inviting me. I have to say that I'm not the most expert in this medical center. There are a lot of my colleagues who are being in the business of teaching about addictions and about prescription medications and not only that, but managing patients. So I'm not the most qualified. I'd say the qualification that I have that got me maybe in this situation is that some of you may or may not know that I lost my son to heroin overdose about 3 years ago. Actually, tomorrow, it'll be exactly tomorrow, it'll be 3 years ago. And you know, when you lose a child, and this is my introduction to the answer, when you lose a child, your world is broken. I mean, literally, you can't figure out where to go. And for me, the innocence, you lose the innocence of the safety around you. So you think the world, the danger is around the corner every time you turn. So my broken world, fortunately, became my word became the whole world, and I came to the conclusion that there is no separation between my word and the real world, which is the outside world, and that's how I got involved in this. I'm a surgeon, so I'm a facial surgeon, and I don't like broken things, you know. And I fix broken faces, broken jaws, fix broken twisted noses, but I don't have the skills to fix what I find broken around me. So that's why I went to school and I wanted to go about it not emotionally, but I wanted to go about it scientifically. And what I learned it revealed to me that we are very broken as a society when it comes to addictions. We're very broken when it comes to management of pain. And those stuff is around me. I mean, I wrote prescription for the tablets of oxycodone. I have vivid memories of asking people, what do you want? What's good for you? And they say, Percocet. You got Percocet, you got it. And so when I learned what I learned, it became even more clear to me that the world around me, which is not my small world, but the whole world, is broken. And I went to school to do this, and that's when I came out. And to me, the thing that was an eye-opener is that addiction is an organic brain disease. The American Medical Association said that. American Addiction Society said that. And I said, disease, that's what I'm here for. That's what I always learned to do, is fix diseases. So I went about it to figure out how to do it. I have to say I'm an optimist, you know, and I love my country. And I say there is probably, I'm an educator by profession. I've been in the business of education for 26 years. I love the slogan. It says, educate, advocate, eradicate. And I believe that through educations probably will do something. And I think it may not be in my lifetime, but I really have a certainty that in this country and this profession of medicine has done that before. We got on diseases. When I first got here, Johnson's has AIDS or has HIV, and I said, oh my God, Johnson's gonna die. And Johnson is still alive, and it's all because of miracles of medicine. And I have to believe in my heart that's exactly what we're gonna do with addiction. It may not be in my lifetime, but I have certainty that we're gonna get there. So just go back to answer your question is, I've been involved into writing prescriptions, teaching how to write prescriptions, and clearly as clinicians, I had nightmares thinking how many of those prescriptions that I wrote end up being in the wrong place, and how many of them actually get initiations. And that is an incentive for me to go back and advocate and educate. Here's the good news. The good news is that for the generation of students that I teach, it's just easy. And the majority of them, they don't have preconceived ideas of prescriptions or pain medicine. It's not 30. You just tell them that we know ibuprofen works. We know that, and they said, okay, you're right. But if I leave you, so yes, we're teaching medical students and dental students, and that's the good news. Not so good news is the clinicians that have preconceived ideas, have habits that are 30 years or 20 years. Some of them will change and some of them not. So the low-hanging fruit for me as an educator is the students and the residents. I've been tracking our prescription pattern in my clinic, and it's going steadily from 2014 until now. I got the statistics today, it's lower than ever before. So I think in the clinics and the residency program and education, don't let me have all your time, it's going to get better. I'm certain it's going to get better because I see it in my statistics that's getting better. I think what I'm not sure about that's going to take longer is changing the views about addictions and the stigma attached to it. I was embarrassed when I found out my son was addicted. That's how I felt. And I'm embarrassed that I was embarrassed now because how could if he had diabetes or he had asthma, I wouldn't be embarrassed about it. This is an organic brain disease. This is what we teach medical students and dental students and our new clinicians. And if we tell them that's a disease, we invoke the best quality of physicians, which is compassion. And once we invoke compassion, then we got at it. They go at it and they're going to fix it. And I'm optimistic about it.
I'm going to go Dr. Best did a lot of work, as was mentioned, looking at prescriptive patterns in the ER and how to effectively change that. And so we'll ask her to comment on it, and then Secretary Hazel maybe to add a perspective from how these changes have actually resulted in potential objective improvements within the Commonwealth. So, Dr. Best.
So I was part of the task force back in January trying to develop some guidelines. We wanted to be very cautious when we talk about guidelines. We don't want to be too prescriptive, to use that term, but never before had we gotten a specific backing about what is appropriate prescribing habits. It's, again, like you said, what works for you, or I don't know, 30 sounds good, or I'm trying to gauge from an emergency physician based on their injury how long I think they might need something. And if the patient was unhappy about what my prescription was or the duration of my prescription, I didn't have any support to say, well, these guidelines say X, Y, and Z. And that's part of what we did in January was trying to develop something that now that we have this crisis, do we have the support when that patient is asking me for 50 fentanyl patches that they can say, well, it's not appropriate, and here are the guidelines that say so. I think one thing that very much clouds this is I see patients every day who are on chronic narcotics, and I see patients a small portion of the time who are there just to score drugs because they are an addict. What I see are people who think that they need chronic narcotics to help with perceived pain or chronic pain or pain that somebody else has told them that they had, and they are an addict. They are addicted to the medication. They're physically dependent on the medication, and they do not see themselves as an addict. And that makes it very difficult from our standpoint, and I have a very short time frame with these patients in the emergency department, trying to explain to them why the medication that they're asking me for is not appropriate, even though they think that they don't have a problem. They'll be the first ones to tell you, oh, all these addicts are really messing it up for the people who need it. And deep down, they're actually the people who need some treatment as well. So we really need to do a better job, I think, in medicine of reframing who is an addict. It's not the person who's throwing things at us, asking me for Percocet and storming out of the ER when they're not getting it. It's, the 50-year-old mother who is on 30 milligrams of OxyContin 4 times a day and can't understand why it's not working anymore.
In our town, CVS Pharmacy has a program where you can get a booth, like a little mailbox put in front of a law enforcement agency for returning narcotics and returning unused medications. And we did one with CBS, put it in about 2 years ago, and we get about 30 plus pounds per week of unused medications returned to our local police department. And Secretary Hazel of the Commonwealth done a lot, and Dr. Best and her group kind of put forward some guidelines. Some of these have been adopted, other programs have been put in place to help decrease the supply, so to speak, of the opioids that are amongst us. And so maybe you could comment on what you're saying.
Sure. Hard to get started. I just wanted to comment on Dr. Abubaker. He is part of a group that is developing learning objectives for medical students. The General Assembly asked us to do that, and he's part of that group, and we are trying to align what we're doing for medical students with dental students, physical therapy, the whole gamut. And in fact, the last meeting was to deal with the non-prescribing community, so that social workers, et cetera, so they would understand what it is we're trying to teach physicians about pain management, prescribing. So that's a good ongoing work now.
Your mic's going in and out.
Yeah, I can tell. Not sure why.
You're so magnetic with personality.
And he started with Honorable. He's setting me up. I don't think this is working very well, but
Can you hear me?
can you all hear me if I just speak up? So a couple of things that I would say. First of all, we don't look, Sam, for silver bullets here. We know it's harder than that. And there are really 5 categories. And I'm going to answer your question about the prevention piece. But we look at harm reduction because treatment is not available for everyone. And there are many for whom treatment is available that they won't accept it. Was with a lady today who had been addicted for 17 years and is now in recovery for 8 in Kentucky, and is part of a program of mentoring parents who have addiction issues. So it's something we have to think about. There isn't a silver bullet. Not everyone is going to be treated immediately, and we do not have available treatment to go to the high-end medically assisted treatment for everyone. We have a gap. The second thing is we do need treatment. We've created the Addiction and Recovery Treatment Services Waiver. VCU sent us yesterday the report on the first few months that came in effect at the beginning of April. We know we have doubled the number of addiction treatment facilities that do medically assisted treatment. The key there is assist. It is a big deal. We've seen an increase in the number of people who have coverage getting treatment. The issue now is what happens when they don't. Third thing I will say is we focus on the prevention piece. We did 2 years ago pass a bill that required physicians to get continuing medical education around prescribing. And that's something that is new and different. We have resisted that as physicians for a long time. Don't want the government telling us what we need to do. But this is one we were able to push through. That sunsets, we'll see how it works. This past year, we put into effect emergency regulations around prescribing for acute and chronic pain that followed the CDC guidelines more or less. We did have to overcome objections, unfortunately, from the physician community to get this. But in the first quarter, we've seen a 10% decrease in morphine milligram equivalents prescribed in Virginia. That is a big deal. Rarely do you see a cause and effect so quickly. The other thing I'll tell you is the drug of abuse is different in different parts of Virginia. In Southwest Virginia, one of the issues is the buprenorphine monoproduct, which has been used as a drug for a number of people in Southwest Virginia. You don't see the heroin there as much as the pills. Due to guidelines put in place by the Board of Medicine, in the first quarter we saw a 35% reduction in buprenorphine monoproduct prescriptions. That is a huge deal because we've also seen a concomitant increase with the combination product, which is safer to use in the treatment of individuals suffering from addiction. Secretary Moran has talked a bit about the law enforcement piece, and I can get the culture change later, but what we are doing is seeing a change, and I am very cognizant of what Sam says. You can be abstinent in jail, prison, wherever, and not be treated. And we can take your opioids away, and you still have an addiction, and then you will go to the street And there's no quality control on what you're getting out there, as the gentleman says. And the issue is not just opioids, it is addiction. The brain has changed. We can't get hung up in opioids because it is already changing. We still have meth. If you're from Galax, meth is still the drug. I think your seizures now are showing meth and cocaine are still highly prevalent in the Commonwealth. Don't get caught thinking about the drug alone. Think about the addiction and the underlying disease, please. Excuse me.
One of the, back to law enforcement, one of the things we learned in our community, and I'd encourage you, if you're in the healthcare area, to work with your local law enforcement to learn this, is we have a huge resurgence in cocaine. And they told us about it several months beforehand because the crime patterns change. And I guess cocaine's associated with much more violent crime. And as they started seeing that, and they started seeing more interdictions on their part with cocaine, we had a big shift. And so Secretary Hayes' point is that it's not opiates, it's an addiction public health crisis. Dr. Peppard, in terms of preventive strategies for communities and for the Commonwealth, SBIRT is a proven tool that we're implementing throughout Virginia, and maybe you can comment on its role potentially throughout the Commonwealth as a preventive strategy.
Sure. Can you hear me? So recently I've been evaluating year one outcomes for our Virginia SBIRT grant. And it's a 5-year grant, but we have had 7 sites launched over the last 7 months and have fully integrated SBIRT top to bottom in their practice, including at Dr. Restrepo's Winchester Medical Center. But as I've been looking and thinking about this concept of multi-dimensional impact, it's actually quite interesting to look at some of the numbers, and I'd like to share with you just a snapshot of what it's looking like today and the impact of SBIRT, at least in the prevention, early intervention realm, which is where SBIRT is most commonly seen. It's a 3-pronged public health approach. We've got screening, we've got brief intervention, referral to treatment mechanisms built in there. Difficult. Is it? Yeah. Okay, I'll talk louder. So is that better? Yeah, I can tell. So I was just saying that SBIRT in and of itself is a 3-pronged public health approach incorporating screening, brief intervention, referral to treatment for risky and problematic substance use. And as I said, we've integrated into 7 practices. The 2 regions that we've targeted with Virginia SBIRT are the Shenandoah Valley region, primarily Winchester, and the Northern Virginia region. And I can tell you that after looking at the outcomes over the last few days, we've screened over 23,000 unduplicated patients just in those 7 sites. Of those screened, 1 out of 9 endorse risky or problematic alcohol or drug use. 1 out of 9. But what I think is kind of amazing and really just speaks to where SBIRT can shine and where we can approach this and change trajectories for people at the other end of the spectrum, more in that, again, that prevention world, is that of those that are endorsing use, this risky and problematic use, 80% of them are low risk, in that low risk category. And that's exactly what SBIRT is designed to approach. I also want to quell some fears because a lot of people have some anxieties around screening at all, right? Because they don't know what they're going to get. But 1% actually are coming up in that severe range, and another 1 to 2% in that moderate range. And you know, there's everything in between. But I do want to highlight that 80% are actually a target for SBIRT. And so what we do is we offer motivational interviewing as the brief intervention. And when we think about a prevention strategy, what I've been struggling with, though, again, and I thought that this was extremely important, is when you think about multidimensional impact and when you think about psychological pain, like Sam brought up, psychological pain is extremely complex, and I've worked in psychiatry 14 years. You all have felt this. You all know what I'm talking about. You can't just treat that with a pill, and you can't treat that with SBIRT. And so we're coming in, and we're identifying these people, and we're offering a brief intervention, but we're sending them home to something. We're sending them home to an environment where maybe social determinants are having an impact and affecting that psychological pain, which is affecting the reason for their use. But when thinking about this, the complexity of measuring impact, one thing that we're considering is looking at what we do, and we do measure comorbidities. So we measure depression, we screen for depression, and we screen for tobacco, and those rates are extremely high in this population. But when you think about what we do with that, there are social determinant screens out there, and thinking about uniting community, thinking about uniting policy and research, and more of this integrated health paradigm of sorts, and considering all those variables is important for that multidimensional impact and not just one evidence-based practice.
So along the lines of the social determinants of health and the impact they have on our communities, and Sam talked extensively about that and some of the challenges that individuals are facing, both when they're in the throes of addiction and also on that journey to recovery and the barriers that exist. So maybe, Secretary, you can comment on your travels in Virginia and the diverse agencies that you work with, what you're seeing as our biggest challenges for social determinants of health in Virginia would be currently.
Well, there's no doubt. Does everyone here believe there's social determinants of health? I've been to audiences where people don't. And I'm going to help you get past that. Think social determinants of life for a minute and picture two 4-year-old boys here. You're largely a Richmond crowd, and one of these boys is from Gilpin Court, and the other boy is from West End. Who's going to do well in life? And tell me what these boys look like. And you all have a picture in your mind right now that their social determinants will impact their opportunity in life to do well. And when you look at the map of the United States from going back to 1999, the CDC has these maps, 1999, 2004 on up, and you can watch the changes as you see the opioid overdoses, which are the tip of the iceberg. It's what Sam is talking about, and some refer to that as the map of despair. And I think that it is complex, but where we have to go, and on the cultural piece, I think is going to be the critical aspect. We won't fix this in Richmond at the Capitol. It will be fixed in Richmond in the community. What you're doing in the Northern Valley with your regional coalition, where you've got the police, the judge, the hospitals, the sheriffs, social services, community service boards, are changing a culture around this. Culture and piece number one is legal and safe are not the same thing. Don't take it. We've gotten away from that. Number two, pain does not require opioids in all cases, and I learned this in Bolivia. I went down in 2001 and 2002 to do surgery and did joint replacements, 25 hip and knee replacements in Bolivia. No patient used an opioid after surgery. No patient got opioid-induced constipation after surgery. Yeah. And these are things where our patients would be dying for medication, and it made me think differently about this in my own practice. That was the seminal moment for me. So there, we do have other modalities. The pain, the opioid for pain literature is highly suspect. Let's just leave it at that. The third piece, and I think where we struggle, and Melly Randall from Behavioral Health is out here, is that only 3 things can happen to someone who's addicted. If you're old enough to remember Woody Hayes, the football coach, Woody, why don't you all throw the ball at Ohio State? He says, when you throw the ball, 3 things can happen and 2 are bad. And when you're addicted, 3 things can happen and 2 are bad. You die, and unfortunately for many, that's merciful, but it's not a good outcome. You live with harm, which I talked about earlier. It's a little bit, but it's infectious disease, neonatal abstinence babies, crime, the family turmoil. We have seen a doubling of the number of kids coming into foster care due to addiction in the last 2 years. Something has to happen for these kids. So this is the harm. And your third option is to get into recovery. And that means the treatment and the support. But if you don't have a place to live and you can't get a job, what happens?
you go back, and these are the things society's going to have to think about, because these people who are addicted are now with us. And recovery is probably a lifetime thing for most. And we can't write them off. We need them back. So I think the hard part around is going to be the culture that says, we understand that you've got this and you're subject to relapse, so we're going to have a drug-free workplace, and we will accept the fact that you might get a urine test and you might be in treatment, but that's okay. We'll live with that as a place to work. And some of the barrier crimes that keep people from working are going to have to go away. I mean, I hate to say it because we tend to get tough on crime, and as Dr. Phil says, how's that working out for us right now with this population of people?
So it's a balancing act in terms of what the proper role of government is and what the proper role of community organizations are and how the interface and the collaboration goes. From your perspective, having a background in law enforcement, sitting in the state Senate, how do you view the proper role of government in terms of supporting communities and individuals as they move from addiction to recovery?
So let me just preface with this. I have worked undercover for almost 7 years. I bought every kind of drug imaginable, served on the task force with Spike Lucas, who I know you know. And probably the turning point for me with regard to true addiction is when I watched a 15-year-old boy help his mother shoot up, and then she helped him shoot up. But the adult in that family was a 9-year-old girl. And I still get emotional today about it because that 9-year-old girl was living in a house with 4 Rottweilers and sleeping in a bed that had feces in it. And when we went to pop the house and take these people into custody, that 9-year-old girl was saying, no, 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 my mom and brother are just sick. And so fast forward, I'm in the Senate. I work with Secretary Moran probably weekly on a variety of issues. But over the last 15 months, I had a great opportunity to put about 143 miles on my hind end. And one of the things I did was I met with every law enforcement agency because I wanted to know what heroin was doing to us. And what I found out was this is not a technical solution, and I like what you're talking about. It's an adaptive challenge, which means I need to adjust my expectations. Somewhere out in the sphere of trying to solve this problem, it's not going to happen right away. It's got to be a collective thing. We've got to broaden that horizon. We've got to make it bigger, and we've got to lower the expectations of how fast we're going to recover from this. But what I did find out, and I've talked to Brian about this as well, is that every community reports overdoses differently. When they do Narcan and they do it, that's not always reported. So we might take that 18-year-old athlete and he's the victim of his own crime, right? He hasn't done anything else but shoot up heroin and ODs. As soon as he's been hit with Narcan and the medics say he's good to go, he's released with no repercussions and no real help on anywhere to go. And so we've got to fix that. So as a policymaker, if you all as doctors, medical providers don't get it straight, you're going to have to rely on legislators to do it for you. And you don't want that. So heed the warnings. If you don't get on board, we're going to be forced to get on board because we have a constituency that is scared to death that their kid's going to be next. And so we don't need to be like Kentucky and say it's 3 days. We want to allow doctors the opportunity and the autonomy to be a doctor. You went into medicine to do no harm. And so what I would tell you as a policy maker is that we need to do more. I spent 5.5 hours in Chesterfield Jail talking to addicts. You want to know what heroin does to people? Talk to an addict, they'll tell you. And I've heard stories from people being abducted and brutally raped and kidnapped, and that's why they are where they are. But I think what the men I didn't have so much sympathy for as much as I did the women in this room that were locked up in a voluntary program that Sheriff Carl Leonard runs. And the doc that runs that clinic is here today, and there he is right there. He needs a round of applause for what he's doing in that jail. But Carl, Sheriff Leonard, has reached outside the bounds of what he's allowed to do with the Department of Corrections. So he's bent the rules to allow a voluntary addiction recovery program within the jail because the services aren't there on the outside. So it got me thinking, how do we get more services As a narcotics detective, we used to seize people's items that were drug dealers. So this year, this session going in, and Secretary Moran have talked about it, I'm going to make sure that law enforcement proceeds from seizures are going to start going to addiction recovery. Because it's hard for us to find the monies. Well, if we're taking them from the idiots that are selling this stuff, then let's put it back and try to help the people that are doing it. Brian and I also serve on the Offender Population Forecast Committee. One of the things that we look at is the data. So we need more data. We need to know when people are overdosing. But my mindset is I want to make sure that an addict has a place to go. And one of the things, and it's outside the box, and I haven't cleared it all with everyone, but once that addict has OD'd, we need to make sure they get into treatment, either voluntarily or forced into it. And I know because there's different policing models out there that allow offenders the opportunity for redemption, because we're not going to jail our way out of this issue. I look at the numbers. Our state is not flush in cash. I can tell you there's no way to do that. But I do know the programs work, and I'll tell you a quick story of how I know they work. I'm in the jail. I see a guy probably a little bit younger than me leave the jail. 15 minutes later, he comes back in the back sally port. And I looked at Carl and I said, Carl, why is he back? Did you guys pop him for a KP, a wanted notice? And he's like, no. I'm letting him back in because if he goes back out and reoffends based on his record, he's going to do 3 years in my jail based on sentencing guidelines, of which I serve on that as well, and I'll talk about that. So it's cheaper for me to let him finish the program and go out and have an opportunity, or at least a smidgen of a chance at recovery and success, than jail him and spend another $100,000 and some odd for 3 years of confinement. And that's the mindset that we have to change in the legislators, for legislators in our community to understand that. One thing we did do, and I commend Secretary Moran for doing that, I serve on the Sentencing Commission with a bunch of attorneys. I am not an attorney, so maybe I'm the smart one in that group. But I will tell you this, we used to sentence people without saying what the actual drug was. So we didn't know. It might be Schedule 1, Schedule 2, but we didn't really know what those drugs were. State police, when they send their data in to the FBI, we can get some of that collective data, but we didn't really know where those drugs were and who were the offenders and where they were coming from. We have that information now. So the more data that we have as legislators and policymakers, the better opportunity we have to actually work with the medical society and those folks in recovery and addiction recovery to actually put money where our mouth is and find solutions. And so I just thank you for being a part of this, this process today, because if we didn't have this dialogue at all, you would get what you get, and then you'd have to throw a fit later. And I can tell you, in the 140-member body that I serve in, everybody has a different idea on how to fix things. And you'll know that in January when we hear 3,000 pieces of legislation again. So the more collective you are in your thoughts, the direction that we go, influence policymakers to allow us the opportunity to kind of collectively get on top of this thing. So thank you.
So a few more minutes remaining. I was going to ask Sam for some thoughts, and if we have a little bit of time, we can take some questions from the audience.
Yeah, I would like to just follow up on what the Senator just said. I think one of the fascinating, radical, but necessary ideas that this epidemic has presented to us is the transformation of jail. In Kentucky, they're doing this, and it's fascinating to see. A number of jails, I think 25 or something like that, have transformed part of the jail into a rehab clinic, a pod or a unit within that jail. Now think about why that's so important. Addicts spend months on the street, basically enslaved to this substance. Every thought, every action is based on getting more or something. And they finally get into, they're arrested for whatever, check kiting, possession of whatever it is, and minor stuff usually. Jail is the first place that they interface with the criminal justice system, usually before they're committing the kinds of crimes that will require them to go to prison. They detox, and for the first time they're thinking clearly. They're thinking without the slavery, pushed, pushed by the hellhound on the heels of dope. And they are able to perceive the clear wreckage of their lives. This is very common to see people go, oh my God, what have I done? Mom won't take my phone call. Dad has disowned me. My spouse has moved to another state. And there's this moment of clarity, a moment of contrition, and it's at that very moment when for decades now we have put people into jails that are predatory, that are, well, above all, they're boring. I would say overall, it's boring. They're ganged up sometimes. There's weird sexual stuff. There's farting. There's a lot of stuff that is not conducive to recovery. They spend 6 months in very, very tense, alternatingly tense and boring environment, leave jail after doing their whatever time or they have to do, and they run right out to get high again because the stress, the lack of recovery is so the lack of opportunity for recovery is so intense, and that there is really nothing for people to do. Now, it seems to me that that is a part of this epidemic. A big part of why we have this recidivism is that people, while at that very crucial moment, it's important to do this in prison, but it's far more important to do this in jail. Jail is where you want to catch people before they. Now, what they're doing in Kentucky is they've, in most jails that I think again 25 or so, they have separated out a pod or a unit. That unit. I visited one in Kenton County, which is across from Cincinnati. It's a fascinating thing. I've been a crime reporter a long time. I never thought I'd see what I saw in that unit. First of all, you have to opt in. You can't be forced in. But there's now a long, long waiting list. You make your bed at 8 o'clock, military style. You're up then. For the rest of the day, you are working on your recovery. There's some downtime for prayer and meditation, a little bit of relaxation, but it's not the whole day. You're working on criminal addictive thinking classes, GED, there's physical exercise, there's NA meetings every day run by inmates. What I saw, I could tell you in this one, is a totally different attitude, a totally different feeling in that pod. It's one of nurturing. Come on, brother, we're in this together, instead of, what can I take from you? One guy, and I was in a meeting in a pod about the size of the footprint of this room, and they have 70 guys, short hair, tattoos on the back of their head, the whole bit. And one guy stands up and he reads a poem out loud to the whole pod. And I was dumbfounded because I thought if that guy did this in another pod, he'd be mincemeat within 5 minutes, And I go up to him and I said, would you, take him aside, would you have read that poem in another pod? Hell no. Hell no, they'd have killed me. That would show to be weak. In regular jail, what works? Showing that you're tough, lying, pride, getting over on other people. All of that is antithetical to recovery. In this pod, I found people who were working together, guys crying when they were confronting in these NA meetings that one guy had pimped out the daughter of his girlfriend to get heroin money. I mean, it's just horrifying stories. It's inmate governance. You're finding people who are like mentors to the new guys. To my way of thinking, this epidemic is calling on us to change jail. That is a linchpin in why this is continuing to happen, I think. And to my way of thinking, every jail, if we cannot treat our way out of this, where are we going to find more treatment capacity? Try citing another treatment center in your neighborhood. See what the response is. How long is that going to take? 3 years to build? And then how much is it going to cost? Way out of the reach of the people who are in jail addicted because of their addiction. So my feeling is that that is a radical idea. It's something as a crime reporter I had never thought of before until I saw it. And when I saw it, I thought, well, duh. That's a magnificent idea. And I wrote if you want to look this up, I wrote a story for the opinion piece for the New York Times opinion page about 6-8 weeks ago. Look up Kenton County, my name, and you'll see a clearer description of it than I've been able to give right now. But to me, that is, it's a step that and it's a much better use of taxpayer money than we've been running jail up to now. It's very important to understand the role jail has in recidivism. In LA, I could tell you what the role jail has in the propagation of gangs is crucial. Nothing good happens in the way we've run jail up to now. Just like Woody Hayes said, I guess. There's but anyway, so I would say that is one place that we, as a society, might well look. That doesn't take more money, by the way. It just takes hiring new people, a few new people. It takes hiring people who have a background in addiction, which is weird. You have to hire a full-time person at a jail who was a former addict. It's a political change of mind more than a financial one.
We just have a couple minutes remaining. I was wondering if there's one of our sponsors is the McShin Foundation. I'm wondering if anybody is here from McShin to kind of bring a push to recovery in terms of from your perspective and the work that you've done. What's going well is basically the question to the McShin Foundation and the recovery program here in the Richmond area.
How am I going? Hey, I'm Michael. I am a person in recovery, so I'm who they are talking about. And there are millions of people all over the country who are recovering. So, this has been kind of dim. So there are solutions, and people do recover. I'm proof. All these people here are proof. My question is, so I work for the McShin Foundation, which is a recovery community organization. It's a peer-to-peer, authentic, grassroots, non-for-profit organization that helps people struggling with substance use, excuse me. We have housing and a recovery center. So to me, the solution is recovery, not medication, or there are lots of different pathways to recover, but my friend David Rook, who's in the audience as well, we kind of tried to come up with a question together, but he says it a lot more eloquently than I do, so I'm going to pass the buck to him real quick.
That was a dirty trick. Well, I think that what we're, Sam, when he was speaking, he said that because we came up with a pill for pain, that we kind of got away from the holistic approach to treating pain. And I think that, if we fall up into where we only want to treat, I think medication-assisted recovery, medication-assisted treatment is part of the solution. But I think if we fall up into the trap of only doing that and not keeping this a holistic approach and involving the entire community in recovery, we're going to end up with the same sort of a problem in the end. So I think, that's basically more of a statement than a question.
And actually, Secretary Hazel and I had a chance to talk about that earlier today, so maybe you can comment on that.
I agree with you. We clearly think when you talk about medically assisted treatment, the key word is assist. And it's all of those things that go with it. I've already stated here, abstinence alone, without all of that, is not treatment, and medicine by itself is not treatment. We find in healthcare, lots of things I've learned along the way as an orthopedic surgeon is that, sometimes we think you need all of these things to make a difference. And then as we get experience and our patients segment out, some do better with one, others do better with another. So I don't think we have the silver bullet yet. I really don't. And when we look at MAT programs, and this is the thing, we talk a lot in government and about evidence-based policies and programs and things like that. So we have evidence that something worked in San Francisco, and now we have 40 of them here. My question is are they all above average? And how do we know? And these are things where we're really missing on the data side of things in the treatment. So when I talked earlier about we tend to want to put people into things, when you get into medically assisted treatment, particularly if you're pushing Vivitrol or something like that that is yet to be proven to be effective, any better than the others, then you're looking at extremely costly programs, and we've got a gap. We've got too many people that are on the street because they don't get the basics, and we've got to make room for that.
Can I say also that I had an interesting experience a while back where I asked I was at a neonatal clinic where a lot of infants are withdrawing from these drugs, born addicted and so on. And they asked me, these nurses asked me, do you know what an infant needs more than anything? Who's withdrawing from these kinds of things? Do you know what? And I confessed I didn't. And they said cuddling. Cuddling, right? Why? Because a baby needs to know that she's in this with other people are there with her, right? And don't we all need that? I mean, it's really, we all need to be cuddled, right? Well, addicts too, and particularly as they're going through this. I agree with Dr. Hazel. The assist is the crucial word in that phrase of medically assisted treatment. If it's just a pill, you're right. We're going to be repeating what we've done with the pain. It's a holistic, a community approach, right? So what does that mean when it comes to this? It means group therapy, mentoring, a variety of ways of bringing people into a community that is not all about, as I said, a little bubble where everyone talks about how to get high all day long. It's about how to move forward all day long. The drug, the substance is part of helping that, but it's only part of it. We're all like those little infants. We all need to be cuddled one form or another, it seems to me.
I just wanted to say thank you for having this forum. Mr. Quinones, thank you for writing that book. I mean, that brought a lot to light. And thank you, Senator Bryce, for elucidating on HARP. But the big thing I want to say is that we need recovery houses when people get out. Because we started a re-entry program also with the HARP, and one of my biggest things is that when somebody gets out, they don't have any place to go. And that's why Sheriff Flynn had us, all the inmates that want to come back, can come back through jail, and which is really against the board of corrections. And so he's taking a big risk by having these people come in. But I just want to let you know that yesterday, in our female HARP program, we had a young lady who was there probably about 3 weeks, was going through the program, but she got out today. She had recently gotten $20,000 in a motor vehicle settlement, and when she was talking yesterday, she said she was very scared about what she was going to do with that money. And so one of our partners is the McShin Foundation, and in one day, I was able to secure her housing for a week at their Echo Flats. And after a week, she's going to go to their new recovery center for women in Chesterfield.
We need to wrap up as the night is moving along, and I'd like to thank the panel and thank all of you for participation. Very much.
I want to thank all of you for joining us this evening. Sam Quinones, I really want to thank you for sharing your work with us. We are so grateful to you, and we're grateful for the work that you've done and the enlightenment that you've brought all of us this evening. Thank you. I'd also like to thank our esteemed panelists once again for sharing your perspective and your expertise. And finally, once again, I'd like to thank our event sponsors and supporters listed on the screen behind me. It's going to take a lot of hard work and collaboration to combat the opioid crisis in Virginia, but it is very heartening this evening to see so many different organizations and agencies represented here. Thank you for all that you do on behalf of the Commonwealth. Thank you, and please have a safe journey home.